I would like to welcome everyone to today's webinar presentation, Transforming Moral Distress into Compassionate Action. I'm Lynn Osborne, Director of Business Development at the Schwartz Center for Compassionate Healthcare, and your moderator for today's session. The Schwartz Center for Compassionate Healthcare is a national nonprofit organization dedicated to strengthening the relationship between patients and their clinical caregivers and preserving the human connection in healthcare. The Schwartz Center Compassion in Action webinar series is funded in part by a donation in memory of Julian and Eunice Cohen. Today's program will be 60 minutes. The first 45 minutes will be introduction and presentation, followed by a 10-minute question and answer session. Today's program is being recorded and will be available on the Schwartz Center website next week. Please note that attendees are participating in listening-only mode, but can interact with the speaker and me by using the questions pane, which should be appearing on your screen. If you have questions, please just type them into the questions pane and send them to us, and we will address as many of them as we can at the end of the formal program. We will also be polling the audience during this session, and we hope you'll participate in this measurement tool. As you exit the webinar, you will receive an electronic survey that we ask you to take a minute to complete so that we may measure your assessment of today's program. Your feedback is really important to us. And now it is my pleasure to introduce our host for today's session, Dr. Beth Lown. Beth is an Associate Professor of Medicine at Harvard Medical School and the Medical Director of the Schwartz Center for Compassionate Healthcare. Beth?
Thank you, Lynn, and good afternoon, everyone. Being able to respond to the vulnerability of patients in a way that provides dignity is a key goal of compassionate care by considering ethics, informed consent, confidentiality, and shared decision-making. Unfortunately, these outcomes are sometimes challenged by resources, policy, or environmental constraints in practice, which can lead to moral distress. Moral distress is a reality of clinical practice. It undermines clinicians' integrity and their capacity for attuned, compassionate care. This experiential webinar will explore the definition of moral distress, its sources and consequences. Dr. Rushton will present a framework for transforming moral distress based on social psychology, neuroscience, and contemplative practice. And now, it's my pleasure to introduce today's speaker, Dr. Cynda Rushton, who's an expert in bioethics and palliative care. And she shares her knowledge through clinical practice, teaching, research, and consultation. She is the Anne and George L. Bunting Professor of Clinical Ethics and holds a joint appointment in the Johns Hopkins University Schools of Nursing and Medicine, Department of Pediatrics, and she is core faculty of the Berman Institute of Bioethics. Her research focuses on palliative care, moral distress, caregiver suffering, and conceptual foundations of integrity, respect, trust, and compassion. Her clinical work centers on the integration of palliative care into pediatrics and the ethical issues faced by clinicians. Cynda, it's a pleasure to welcome you here today.
Thank you so much, Beth, and welcome everyone. Hope you're all in a comfortable place for us to spend a little time together talking about this important question. As I begin, of course, no one comes to their work alone, and so there's many people who have had a significant impact on my journey, and many of those people are listed here on this slide, but in particular Roshi Joan Halifax, as well as my colleagues in the Being with Dying program, and many, many others who have influenced what I will share with you today. As we begin our time together, I wanted to start by first remembering why we're all really here. Most of you on this call are probably clinicians who are caring for people across the lifespan, at the very beginning of life, and people who have lived a very full life. And as we begin this conversation about moral distress, I want us to begin by touching back into why we have chosen the paths that we have in healthcare and why we're doing the work that we're doing. So just take a moment to recall why you're really here. As we go through this time together, I would also invite you to take this opportunity to really connect with yourself. A lot of times when we talk about moral distress and some of these issues that come up in healthcare that are so problematic to us, we overlook what our bodies and our emotions and our minds are helping us to understand. So I would invite you, as we go through this session together, to really notice what's happening, including your sensations in your body that include your breath and your heart rate, your muscle tone, any feelings that begin to percolate up as we talk about this topic, and what your thought patterns are. Our thought patterns often can reveal a lot about how we frame and respond to these issues. So whatever level of comfort you have in exploring in that way, I invite you to do that. So we're going to talk about moral distress today, and this is a topic that has been in the literature since the early 80s, and it was first coined by Andy Jameson. And since Andy's initial work, that definition, I think, has evolved and perhaps has become more refined. So for our purposes today, I'd like to propose this definition of moral distress as the pain and anguish that affects our whole being, our minds, our bodies, our relationships, in response to a situation where three things are present. First of all, we acknowledge there's a moral problem. Second, we acknowledge that we have some moral responsibility to do something. And third, we make a moral judgment about what would be the correct action to take in that circumstance. But as a result of real or perceived constraints, we end up participating in something that we perceive as wrong, in moral wrongdoing. So from this definition, we have begun to realize, initially we thought that the reason that we had moral distress was because of them, because of the system, because of others. But what we begin to realize is, in fact, it's both. There are sometimes obstacles within us as individuals and in our external environment. But the bottom line is those factors and conditions create the environment where we act against our personal values, and by doing so it undermines who we really are, our integrity and authenticity, and often causes us painful feelings and or psychological disequilibrium. And most of us in healthcare have experienced this many, many times. And so what we wanted to do is to invite you to reflect on your own experience over the last 6 months. Given that definition, how often have you experienced moral distress? And I'm going to turn it over to Lynn at this point to get your feedback.
Thank you, Cynda. To our audience, we'd like you to answer this question using your chat pane, polling pane, on the webinar screen, and let us know whether you've experienced in the last 6 months moral distress daily is the response number 1, weekly number 2, monthly number 3, or 4, not at all. And if you could give us your responses to the poll, we'd appreciate your input. We're getting 54% here. We'll give a couple more moments to give people a chance to find that polling pane and put their votes in. Looking great. Okay. At this point, we're going to close the poll. And we have 75% that voted. Here's your responses, Cynda. We've got daily 10%, weekly 35%. Wow, that's high. Monthly 42%, and not at all, only 13% of our audience.
So actually, unfortunately, these results are not surprising. It looks like about more than 75% of people on this webinar are experiencing moral distress pretty regularly. So that is not at all surprising and very consistent with what we've learned in the literature about moral distress. So as we think about moral distress, we know that it is a pervasive issue in healthcare, We know that a lot of the research that has been primarily done in nurses, but that is not in any way to suggest that other members of the healthcare team do not have moral distress, and in fact it's a real gap in our knowledge about moral distress and how it affects physicians, social workers, chaplains, respiratory therapists. But if you look at the nursing literature, it's pretty clear it's a very common experience. 1 in 3 nurses have experienced moral distress. Almost half of those nurses that were studied left their units or the field because of their moral distress. And an interesting factor here is that the intensity of moral distress is higher than the frequency. So the fact that people on this particular webinar are experiencing moral distress frequently doesn't give us any idea about the intensity of how they are affected by that moral distress. So the fact that it's frequent and possibly intense at the same time suggests that it is a problem that needs very focused attention, both individually and in our healthcare system. So in slide number 12 here, if we look at even further at this issue, you can see that the impact of moral distress is very significant as well. It can lead to undermining nurses' moral integrity, and one of the consequences is that people begin to detach from their work, from their experiences, and withdraw from the situation because they're no longer able to deal with the stress that they experience. We also know that these repeated experiences of moral distress create what we call a moral residue. And we're going to come back to this in a few minutes. But frequently, when you think about your experiences of moral distress, they are often experiences that have happened some time ago. And those unresolved feelings are still present months and years afterwards. Beth Epstein and Ann Hamrick have done some interesting work describing what they call a crescendo effect, is where there is the accumulation of moral distress and moral residue over time. So for now, I'd like to invite you to bring into your awareness an experience where you have experienced moral distress yourself. And you can choose whatever situation you feel comfortable with. But as you recall that situation, I'd like to really invite you to notice what begins to happen. What do you notice in your body? What sensations do you notice that you associate with this memory? What feelings are present or begin to emerge? And just to notice your thought patterns. What kinds of thoughts do you have about this experience of moral distress? And as you do that, notice what kinds of feelings you associate with your story. Are they feelings of exhaustion, despair, regret, anger, something else? Or is it more spacious and calm and a sense of harmony and well-being? Notice where you carry these feelings in your body. And it could be that there's tension or relaxation in your shoulders, in your neck, in your chest, anywhere that you might sort of associate this memory in your body is really important to notice. And as we go through the rest of this presentation, you'll understand more about why that is so important. And also just your thought patterns. Are your thought patterns one of self-judgment? Are they focused on what went wrong, who's to blame, why did this happen to me, or are they more spacious inquiry questions about meaning and how you've made sense of this experience? All of those are important pieces of data in beginning to understand our own responses to morally distressing situations. As you think about your own experience, what are the kinds of situations that have caused you moral distress? And what is it about these situations that have caused challenges or problems for you? Understanding our own patterns and the kinds of circumstances that can cause moral distress are very, very valuable in trying to then transform them into situations where we can actually do something about them. The literature is replete with research that documents the sources of moral distress, and here are just a few of them. Many of these will be familiar to you. At the top of the list is causing harm to patients. I was just with a group of PICU nurses this afternoon who were talking about their moral distress and despair about doing things that they felt were causing harm to a patient. And part of that was related to overly aggressive treatment. The issue of inadequate pain management. How can I make sense of my role as a doctor or nurse when I am actually causing pain or not being able to relieve pain or suffering? There are many sources of moral distress that have to do with communication. Poorly defined goals of care, situations where we disregard patient choices, where maybe we haven't given complete information or selective information in the consent process, or even lack of informed consent at all, where we haven't really helped people to understand what they're choosing. We also have seen patients where we've begun to objectify them as non-persons. Certainly the issue of feudal treatment is a constant theme in our refrain around moral distress. And these last two, I think, are really important. One of the consistent themes in the sources of moral distress has been inter- and intra-professional conflict, often related to authority differentials. So this issue of teamwork and collaboration and our lack of ability to work effectively together as a team has contributed to moral distress. The last one, inappropriate use of healthcare resources, I think is going to be one of the factors that in the future is going to continue to escalate as we try to understand this healthcare system and how we can begin to think about our obligations as clinicians. For those of you in the clinical arena, you may have heard some of these refrains. Things like they, whoever that is, maybe it's the family, maybe it's the patient, want us to do everything, and we don't want to do everything. Maybe it's they, the doctors, or the legal department, or sometimes in my world, the ethics committee, is making us do something we don't want to do or keeping us from doing something that we think we ought to be doing. We often hear the refrain of there's nothing more I can do, and certainly from my nurse colleagues, this issue of I can't stand to watch my patient's response as I suction them, as I do treatments, as I give medications. Sometimes we perceive that people don't care, and often we say this is futile and therefore we should stop doing these things because they're ineffective. But the most common thing that we say is, why are we doing this? And that refrain, I think, has become a code word for us in trying to unpack when is moral distress present. And when we hear that refrain, I would say that it is an opportunity to pause and to ask why. Why is this particular refrain coming up in our work, and what's actually at stake here ethically for the patient, for the family, and for ourselves? We also know that moral distress affects our whole being. It affects us physically, and there's a long list of symptoms that suggest how moral distress impacts our bodies. It impacts our emotional state, both from standpoint of anger and resentment, but also in terms of depression. There are behavioral manifestations of moral distress. Victimization, what we've now begun to call disruptive behavior, may well be a symptom of unresolved moral distress. And as well, spiritual impact, often associated with how it is that we create meaning of our work and how we find a connection to something larger than ourselves. So as we think about this issue of moral distress, one of the issues that I think makes this such an urgent question for us as clinicians and as people who work in healthcare is the residue that can accumulate when we are not able to fully resolve these kinds of questions, and what happens when we compromise our sense of integrity, of who we are and what we stand for and our character. So I'd like to just pause here for a moment and to acknowledge that moral distress is a part of the path that we have all chosen. It is not likely to go away, and in fact will probably intensify. And so the question for us is, how can we begin to think about moral distress not as victims, but as a sign of our deep commitment to our patients, to our families, to our chosen professions, instead of a failure. Because often when we hear the stories around moral distress, they are very much stories of victimization. They are stories of helplessness and powerlessness. And instead of remaining in that narrative, I would like to propose that we need to begin to think about how we understand this threshold for caring for ourselves and caring for each other so that we can take care of the patients and families we're called to serve. And it's also true that we have to be clear about what the boundaries are, how much suffering is justified for a clinician to endure when it causes a deep fracturing in who they are and their well-being, which we know has huge costs on patient care. So let's look forward. As Helen Keller says, although the world is full of suffering, it is also full of overcoming it. And so what I want to do in the remaining time here is to share with you some work that I've been doing for a number of years now, looking at how do we move from our usual methods for dealing with moral distress, which has primarily been focused on moral reasoning and communication and conflict. We've done work on interprofessional and interdisciplinary collaboration. We've tried systems reforms, ethics consultation, and even grief counseling and employee assistance. All of these are important, but they haven't yet really helped us to move to a different place of dealing with moral distress in a way that helps us to actually mitigate some of the negative consequences. So the solutions are going to involve both personal, professional, institutional, community, and society. But I'm going to focus first today on the personal, and to see if we can begin to acknowledge that moral distress is a part of the fabric of the work that we do, and see how we can relate to it, not as a sign of weakness, but perhaps as a sign of courage, as a sign of our deep commitment, not of a sign of our failure. So I'm going to share with you some work that I've been doing with Joan Halifax and Tony Bach and Al Kazniak. And this work actually brings together some work that we've been doing on the interface of moral distress, empathy, compassion, and personal distress. And it brings in work in neuroscience and social psychology that focuses on our response to suffering and how it relates to both empathy and compassion. So before I begin this, I want to make a distinction between empathy and compassion. And Roshi Joan often makes the point that they are not the same. And I think it's important to distinguish these two qualities. First, by saying empathy is often described as feeling with, the ability to vicariously share feelings of empathic concern and compassion with another person, and feeling as they do, attuning to their feeling state. And as we've had more research and academic writing in this area, empathy is being recognized as a step in a complex of responses that lead to these feelings of empathic concern and compassion. So in one way, you might say that empathy is the precursor or the precondition for compassion. Whereas compassion can be understood as feeling for another, but it's not necessarily isomorphic to the sufferer's affective state. It can be described as the emotion one experiences when we feel concern for another's suffering and our desire to enhance that person's welfare. And so when we think about this, we want to look at how we begin to create the conditions for empathic attunement so that we can continue to respond with compassionate action. So I want to share the work of Daniel Batson, who did some really interesting research looking at what motivates people to help others. And his work was really important because he began to articulate two distinct emotions that motivate others to motivate individuals to help others. The first is empathic concern, and the second is personal distress. Empathic concern is described as the other-focused, kind of congruent, that attuned emotion produced when we witness a person's suffering. It is often accompanied with feelings of tenderness, empathy, and compassion. And in contrast, the other motivation for helping others is personal distress. And the difference here is that we are motivated to help others in relieving their suffering, but the difference is that this is focused on the self. It is prompted by the need to relieve our own uncomfortable feelings, and often leads to behaviors that are motivated by a desire to protect ourselves from negative emotional arousal. Now, this isn't often a conscious process, but it may in fact be the motivation that emerges, and our ability to sort of self-regulate is related to how we respond to witnessing suffering, either as personal distress or empathic concern. In terms of regulation and balance, what we see in moral distress is that when we see someone suffering, when we see what is happening to one of our patients, and our arousal to that situation is not regulated, it is more likely to give rise to personal distress. So if we're unregulated, we become aroused by what we're seeing and what we're participating in. We may slip into personal distress, and that undermines our ability to express compassion and can lead to self-focused behaviors such as avoidance, abandonment, and numbing, which are all common stress responses that are aimed at relieving our own distress. And I want you to just think about your own experience and how you relate to that experience, how you responded to your experience of moral distress. Nancy Eisenberg took this work even further, and she did interesting work looking at the preconditions for empathic arousal, and she describes three preconditions: empathy, which is emotional attunement, perspective taking, which is cognitive attunement, and memory. And what she began to explore was that empathic arousal can precipitate either positive or aversive responses. So it activates parts of our brain, and again, if we're not well regulated in our emotional regulation, and we are not able to differentiate ourselves from the other, so this is not me that is experiencing this pain or suffering, then it can lead to a situation of empathic over-arousal. And that happens when our empathic arousal becomes so high and we perceive that experience as negative, we're more likely to shift into personal distress rather than empathic concern, where we're concerned about the well-being of the other. In looking at moral distress, we also included as a precondition moral sensitivity, which is the ability to attune to others, but importantly, to discern the morally salient aspects of a situation, to be able to locate what are the issues, what are the factors and contexts that are important in deciding what would be the ethically correct thing to do, and appreciating how our own actions will affect ourselves and others. And this approach is very much consistent with an ethic of care that allows for emotions and relationships, intimate relationships to be a part of that reasoning process. Moral sensitivity also importantly involves conscious and unconscious processes, and it's related to the development of conscience, that sort of barometer that helps us to realize when we are acting in alignment with our values, which is integrity, or when we are violating them, when we have conflicts of conscience. In thinking about moral sensitivity, why it's important is that if it's not well developed, we may not recognize occasions for moral action, or we may inappropriately tolerate situations that really require our action and our responses. So the final part of this process of trying to think about how we can transform moral distress is to focus on the issue of resilience. And how do we cultivate more capacity within ourselves as clinicians to be more buoyant and resilient in the face of moral distress? Our ability to come back to baseline. And my colleague Lori Leach, who has done some magnificent work in social resiliency, talks about this as our resilient zone. So when we become activated by seeing the suffering of another person, we're able to experience that charge but release it within a zone of resilience. In contrast, when we're not able to do that, when we are empathically over-aroused, for example, we're bumped out of our resilient zone, and we can be in what is called sort of hyper-aroused state, hyperactivity, hypervigilance, irritability, anxiety, or in addition, we may end up in a hypo-aroused state, which is often characterized by behaviors of depression, disconnection, numbness, and that we can begin to dysregulate in the face of moral distress. And so what we've done, and all of this is included in 2 papers that we published in the Journal of Palliative Medicine in September this year. If you want more information about it, there's lots more to be explored. But what we're looking at is these preconditions of emotional attunement, cognitive attunement, personal experience, that impact of memory. I've seen this before, and the possibility that we might project that experience into the current situation, and moral sensitivity are precursors for how we experience the arousal of witnessing suffering or participating in acts that we think compromise our integrity. The idea is if we can maintain a sense of stability in the face of that, it's more likely that we can maintain that empathic concern, our concern for others, and engage in principled, compassionate action. In contrast, if we become dysregulated, it is more likely then that we will move into personal distress that can lead us into behaviors of avoidance, of abandonment, of numbing, of unregulated moral outrage, and leading to an experience of burnout, of acute secondary stress, sometimes called compassion fatigue, although that term is probably incorrect, and also just unregulated reactions. So this framework offers us an opportunity to think differently about how can we begin to shift our experience of moral distress from a self-focused orientation to altruism, from victimization to self-efficacy and agency. One of the features of moral distress is helplessness and powerlessness. And from despair to hopelessness, and depletion to resilience. So what I want to share in these last few minutes is some thoughts about how we might get there. First of all, we've got to start with our own situation, and we've got to begin to pay attention to what we need as clinicians and as people to be able to begin to self-regulate our own experience. That prioritizing our own well-being is not a selfish act. It is, in fact, an ethical requirement. Certainly in nursing, we have as a part of our code of ethics a requirement that nurses care for themselves in addition to caring for others. So there's an ethical mandate here that I think undermines our commitment to ourselves to create systems individually and within the organizations that we work in to address these very important issues. So things like mindfulness, ability to stabilize the nervous system so that when we are aroused and activated by situations that we can regain our sense of stability much more quickly and without so much cost to ourselves. The ability to develop insight so we can distinguish self from others, that the experience of my patient's pain is not my own, where we can recognize our own personal triggers of moral distress and symptoms of empathic over-arousal. Mindful practice is really at the heart of all of this. If we want to maintain that sense of stability, we want to cultivate through whatever pathway is appropriate and meaningful for you to allow yourself to become more present in that moment-to-moment attentiveness to our own mental processes, our body's experiences in the day-to-day, moment-to-moment experience with more clarity and compassion. And so as we've suggested here today, we can be mindful of our body, of our feelings and emotions, and our thoughts and attitudes. And one of the really promising areas that I would offer to you to consider is Marilee Adams' important work on how do you change your life, change your questions, change your life, which is about shifting your mindset from the judger mode, which is generally negatively based, we're wired for negativity, to a learner space of inquiry, where we can begin to notice and to pay attention to what's happening in our bodies, in our relationships, and with each other. If we had more time, I would invite you to start first by really taking your own pulse and being able to notice the connection of your own body's heart rate, your heart beating, and your breathing. As much as you notice all the patients that you take care of and whose pulses you have probably, some of you have taken thousands and thousands of them. And yet we forget about our own well-being, the own gift of life that we have in our bodies as well. So starting by taking note of who we are and our own well-being, and cultivating qualities that we might call ethical mindfulness, which is a stance of clarity and non-reactivity, being able to be really focused in the moment. I was working with this group of clinicians recently, and one of the observations we made was how difficult it was to accept that the family member of this patient didn't see things the way that we did. How much suffering there is when we are expecting people to respond differently to the conclusions that we've come to as a clinical team, wanting them to be different than they are, wanting things to be different. So listening differently, being able to be attentive to our own experience and that of others, to observe and to see what we may be missing in those instances. To cultivate a quality of humility, which is about curiosity. It is not about expertise and knowing the answer. It's about having the capacity to have awareness around our confusion and our feelings of incompetence, our helplessness. Discovering what would really serve instead of feeling like we have to know what the answer is and telling and offering that to others, but discovering it together. Letting go of our own self-interest, our position, our authority, the outcome that we want, and really being courageous. Sometimes that requires principled moral outrage, to deal with it from a place of stability rather than reaction. And sometimes we need to conscientiously object to situations that we're involved in. But again, from a place of compassion and clarity rather than reactivity and anger. I would also suggest to you the wonderful work of Rushton in her model of compassion that she has distilled now into this mnemonic grace. It is a very helpful, it appears very simple, but a very complicated and complex set of skills, starting first with gathering our attention, thinking about those situations where you experience moral distress. How do you gather your attention? Recall your intention, which is about remembering why you're really here and seeing that as a resource to support us through challenging times. Attuning to ourselves first and then others. C is considering what would really serve, and E is ethically enacting and ending whatever encounter that we're engaged with. There are also a number of things that we can do in our clinical work to create more spaciousness around these experiences of moral distress. And I'm just going to mention a few of these. These are also in a piece that I wrote a few years ago about ethical decision making and the art of pause. But often when we're in morally distressing situations, if you think about it, we are stuck in a very contracted space. It's hard for us to find space for possibilities. And sometimes what we need is just to slow down ourselves, to slow down the process, to create space for inquiry. And that can look like monitoring and anchoring yourself in your breath, being transparent about what we know and what we don't know, monitoring our mindsets, and noticing, as Marilee Adams so beautifully suggests, noticing when we've slipped into a judger mindset and how we can shift ourselves back to a space of inquiry and learning. Paying attention to our own personal responses, asking for clarification instead of assuming or making assumptions. Creating enough space where we might ask, is there another way to see this situation? I was just today talking with a group of my colleagues who were very distressed that this family member couldn't shift their perception about what ought to be done. And one of the questions was, is there another way to see this? Is it possible that we could relate to this person from a place of compassion as a human being who is clearly suffering themselves? How can we connect to them differently? What else is possible here, rather than the one outcome that everyone seems to be committed and attached to? Letting go of those outcomes doesn't mean that we're letting go of our competence or our authority or our knowledge. What that means is being able to let go of only one way of seeing the situation, letting go of what we're attached to and creating more space for what is possible. I'd like to end by inviting you to remember a time where you really served at your highest capacity, where you were really proud of the service that you provided to one of your patients. And notice as you recall that moment of service, that moment of compassion, what body sensations that you associate with that memory. Notice the feelings that you carry around that memory. And notice the thoughts that you have as you recall this moment of service and of compassion. Because much of our energy is spent on the very few instances of moral distress that occur. And it completely obliterates the hundreds and thousands of moments where we actually were able to serve with compassion, with integrity, and with respect of ourselves and others. So as we end today, I'd like to invite you to connect to that memory, to hold it as a touchstone for yourself as you experience yet another morally distressing situation. Because by doing so, we will find that there are more resources, there are more possibilities than we have considered, and the opportunity to help ourselves as much as we help others. Thank you very much.
Thank you so much, Cynda, for your wonderful insights and your deep experience. We do have time for some questions, and we have some questions from the audience that I'd like to turn over to you. The first question is, do you think that nurses are comfortable addressing the spiritual dimension within themselves or their patients? And if not, how can we improve that?
Well, I think the answer to that is, of course, it's a continuum. There are, like all of us, some people who are very comfortable and gravitate in that direction, and there are others who do not. I also think that there is a kind of deep wounding that we have in our training and in our organizations that doesn't create very much space for us to connect to that part of ourselves. And so I think one of the antidotes for the intensity of moral distress that people experience is to begin to incorporate more space, more opportunities for us to connect to that part of ourselves.
Thanks, Cynda. Is there any role for connecting with each other in community? How have you found that to be helpful as well?
Well, it's interesting. As I said, most of the research has been done on nurses, so for my physician colleagues and others, what I'm about to say isn't based on evidence, but it's very clear that for nurses, one of the main sources of support is their colleagues and being able to be in relationship with them and to speak about these issues. That said, we have found that there are important ways in which all members of a community who can come together around their shared commitment. It's like a balm for some of the distress. It does create a sense of solidarity. And I think a really important aspects of creating healthy work environments is to pay attention to how we create the space where interprofessional groups of colleagues can come together, like Schwartz rounds and other things, to really talk about what experiences we have, how cases that we are involved in affect us as people and as professionals, and to think about the impact of that ultimately on the quality and safety of care that we provide.
Absolutely, absolutely. And these opportunities to listen, to offer, and to receive support are rare, but they're such treasures. Well, we have couple of other questions, several other questions. I'd like to ask this one from one of our listeners. Can you speak to palliative care, not in life-ending illness, but life-altering illness, especially as it relates to premature infants and their parents?
As a source of moral distress?
I assume so, yes.
Well, that's a great question. I have spent a fair amount of time with that whole area, and I think that again, there are many sources of moral distress that have to do with our different perspectives that families have, that we have about quality of life, what is a life worth living, and oftentimes those viewpoints clash when we start thinking about what's the right thing to do for a premature infant. It can range from questions about, what is the brink of viability? How do we think about the boundaries of parental decision making? And that's absolutely an area where I think many of us struggle in pediatrics, is around how we think about this continuum of professional authority, paternalism, parent authority, and the balance between the two of those in shared decision making. And my own sense is that, in the 80s we went from paternalism, and now we have gone to a place where many clinicians feel that they have to do everything that is requested. And in some ways their professional judgment has been erased from the equation, which causes a great deal of moral distress, particularly for our physician colleagues. And I think that we are at a place where we need to come back to a more balanced center. I'm not completely sure what that will look like, but I certainly think that we need to be engaging with family members and clinicians about what is that right balance and what would a process look like for us to come together around decision making that is trustworthy and respectful, and it really acknowledges the limits of what we can and cannot do, which are very real, particularly in that environment.
These are hard questions, aren't they? Very hard questions.
Totally.
This is about really integrating the expertise of the patient, of the family, about their worlds, with the expertise of the clinical staff about what makes sense in their professional judgment. It's the meeting of two worlds and the co-creation of really a compassionate pathway forward.
Exactly.
Not so simple. No, it's so simple. Here's another question. This is a question from a community health worker in primary care practice, who says, I work with the sickest patients who have life barriers that get in the way of their health, and I assume that this is a source of significant distress for this particular person, and they asked, do you have any tips for me?
Hats off to everyone. I think we all are seeing so clearly the intersection of social lifestyle issues and health. And I think this is an area of moral distress that has been largely unexamined. And I think many of the things that we've talked about today on this webinar would be useful in that environment as well. But I also think that we need to have much more dialogue and inquiry and exploration into some of these very important issues. And one that comes to my mind is the issue of people who are labeled as non-adherent or in some cases non-compliant, and the way that we as clinicians respond to them, the assumptions that we make about them, and often what's missed is the interplay, the very important interplay of the social situation, finances, of poverty and education on a person's ability to, quote unquote, follow the treatment plan. And so I think that's a huge area of opportunity, and I would love to see some real targeted work done in that area.
Mm-hmm. Sometimes it's really a matter of raising awareness about what these issues are for the healthcare team, so that they can live in the shoes of the patient or the family member who's unable, simply unable to follow through, as you say. This is another question. Someone had a question about what you meant when you said that the phrase of compassion fatigue might not be quite appropriate. Can you dig into that a little bit more?
Sure. The term compassion fatigue has been adopted by many people, and it certainly is a label that indicates the kind of distress and suffering that clinicians experience. What I was referring to is compassion in and of itself, and His Holiness the Dalai Lama was actually asked this question. And his response was that compassion can never be depleting, because the definition of compassion is one of balance. It is about, as Roshi Joan would say, the balance between a strong back of equanimity and an open heart of compassion. And so to call what we do compassion fatigue suggests that compassion in and of itself is what can be fatiguing. And I think his comment is that it's probably empathy fatigue that we're experiencing, and perhaps empathic over-arousal rather than compassion fatigue.
That's interesting. Okay, here's another question that's really tough. What advice can you give when the cause of moral distress is system-based and the individual who's experiencing the moral distress is being asked to do something that he or she feels is not right, but is condoned by the organization, maybe even mandated by the organization in which he or she works?
Great question. And I'm going to answer it in two ways. One is that we all work in very complex situations, and I think that each and every one of us has to create our own moral compass and determine how much effort we are willing and able to put into, first of all, identifying situations where our integrity is compromised, taking action to address those situations, sufficient amount of effort to try to address the issue and perhaps the root causes. But I think the bottom line for every single person is that we have to assess ourselves when we've reached the threshold for how much of a violation of integrity we are willing to endure in the context of our workplace. And it's an important discernment process. Is this an isolated incident? Is this a pattern of behavior? Has there been any response to the issue being acknowledged and brought forward? Sort of that idea of conscientious voice. Has it been raised as an issue? Has it been framed as a threat to one's integrity and a violation of conscience? And what has the response been? Because once one has engaged in those kinds of activities, it's important to ask yourself, what's the cost to me to continue to work in this environment? And it may be that the cost to your own personal well-being, your emotional state, to your sense of who you are, means that you need to leave that organization. Because there's clearly not a deep alignment between our values. We know that when our values are out of alignment, we feel depleted and exhausted. And that does take, I think, significant cost on us as human beings over time.
What a great answer to
Cynda,
a complicated question.
Great answer. And Cynda and Beth, I'm sorry, we've come to the end of our program. I'm inspired, and I want to thank Dr. Rushton and Beth again for sharing both your expertise and insights with us, as well as everyone in the audience for setting aside time in your busy day to participate in this webinar. We hope you will join us for upcoming webinars provided by the Schwartz Center in our Compassionate Care webinar series, including, and it seems like a ways away, the space between self-esteem and self-compassion on October 9th. We know how busy you are, and we very much appreciate your taking a moment to complete the electronic survey upon exiting today's program, and we greatly value your input. Thank you, and have a great day.